We have started a series of questions related to competitive exams, which might help in pharmacology. So today's topic is on osteoporosis. I have made a presentation of 5 questions related to osteoporosis, which I would be explaining. So let's start. The first question, which of the following vitamin D preparations would be the most appropriate in a patient with poor renal function? So the options are calciferol, calcitriol, cholecalciferol, and ergocalciferol. So before explaining the answer, let's learn a brief about these options. So here I have mentioned some vitamin D related agents. These are the agents which involve cholecalciferol, ergocalciferol, doxorcalciferol, calcifediol, and calcitriol, and their chemical natures, along with its duration of action and the organ that is required for its metabolism. So amongst the options, the first two options are cholecalciferol and ergocalciferol. These two are vitamin D3 and vitamin D2 respectively, and it is the precursor and the inactive form of vitamin D. And to metabolize this into its active form, we require liver and kidney. But as we had seen in the question, the patient has poor renal function, so we need a form of vitamin D which does not require kidney for its metabolism. So as we can see, calcitriol is an agent which does not require any organ for its metabolism since it's already in its activated form, which is 125 dihydrocalciferol. And so the answer would be B, which is calcitriol. 1-hydroxylase activity must be adequate to produce 125 dihydroxy D3. Calcitriol is the only choice that is already 1-hydroxylated. So calcitriol is already in its active form, and since it's active, it does not require any further metabolism. So it is the preferred agent in patients with poor renal function. Let's move to the next question. Intermittent administration of PTH produces which of the following? PTH here is parathyroid hormone. So the question is intermittent administration, and it is not prolonged administration. So the options are impaired calcium absorption in the gut, inhibition of 1-hydroxylase, net increase in bone formation, and net increase in bone resorption. Let's learn a brief about parathyroid hormone. So parathyroid hormone is secreted in response to low serum ionized calcium. So whenever there is hypocalcemia or low calcium present in the serum, parathyroid hormone is secreted as a response. But if parathyroid hormone is continuously elevated, as we can see in cases of hyperparathyroidism, it increases osteoclast activity via increased rank L. So there is a signaling pathway called OPG rank L signaling system, which we will learn in the next questions. So continuously elevated parathyroid hormone leads to osteoclast activity, which further results in bone resorption. But pulsatile release or intermittent release of parathyroid hormone activates osteoblasts. And the function of osteoblast is to increase the bone formation. So our question asks about intermittent administration and not continuous or prolonged administration. So in this case, the answer would be net increase in bone formation, as we can see in the answer. Intermittent administration of parathyroid hormone on its analogs will result in bone formation. Continuous dosing or a parathyroid hormone secreting tumor will cause bone resorption. So if a tumor is formed which continuously releases parathyroid hormone, so that will cause increased osteoclast activity and thus might result in net bone resorption. But this question asked about intermittent administration. So the correct answer would be net increase in bone formation. So let's move on to the next question. We have a case here. A 53-year-old woman who is being treated for metastatic breast cancer is noted to have some lethargy, fatigue, and an elevated serum calcium level. She is brought into the emergency department for near comatose state, thought to be caused by hypercalcemia. After addressing the ABCs, airway, breathing, and circulation, which of the following is the best therapy for this patient? So we have a 53-year-old woman who is being treated for metastatic breast cancer, and she has been noted to have lethargy, fatigue, and elevated serum calcium, that is hypercalcemia. So after addressing her airway, breathing, circulation, which would be the best therapy? The options we have are bisphosphonates, calcitonin, IV estrogen therapy, and saline infusion and furosemide. So furosemide is a loop diuretic. The answer would be loop diuretics given with IV normal saline are the best choice in a patient with acute onset hypercalcemia. So this case is of acute onset hypercalcemia. In cases of chronic hypercalcemia or prolonged hypercalcemia, we might give a combination of other drugs also including bisphosphonates or maybe calcitonin. But since this is acute onset, the best choice of drug would be a loop diuretic as it increases the excretion of calcium and thus would be able to manage hypercalcemia. IV estrogen therapy is not preferred since patient is already suffering from breast cancer and estrogen is known to aggravate breast cancer in certain cases, especially if it is estrogen sensitive breast cancer. So IV estrogen therapy would not be a good choice. For acute onset, furosemide or loop diuretics are the preferred drugs. Let's move on to the next question. A postmenopausal woman with a family history of osteoporosis completes a bone mineral density workup and you find her T-score is minus 2.6. So let's learn a little brief about the T-score. I have a scale here. So as we can see, the normal range is from -1 to more than +3, which is, or like more than -1, T-score is considered as normal. Low bone density is the range of -1 to -2.5. And if a patient has less than -2.5 T-score, he or she could be considered to have osteoporosis or porous bone, which can lead to fractures. So the patient mentioned here has a score of -2.6, which is less than -2.4. So we can consider it as osteoporosis. So she tried a short course of teriparatide a year ago, but complained of serious depression and mood changes. So teriparatide is a parathyroid hormone analog or a synthetic form of the parathyroid hormone. Depression and mood changes are its side effects. So you elect to try an antibody-based therapy and schedule a time for an injection. Which of the following is the drug you have selected? So the options we have are calcitonin, dihydrotachysterol, denosumab, and infliximab. So we need to choose an antibody-based therapy. So for that, denosumab is an antibody against rank L. So rank L is usually seen in the osteoclast activity. So it activates the osteoclasts, which further results in bone resorption. So denosumab acts on rank L. It blocks proliferation and activation of osteoclasts and is administered every 6 months by subcutaneous injection. So denosumab would be the preferred drug of choice in this case since it is an antibody that directly acts against rank L and blocks the proliferation and activation of osteoclasts. And it needs to be administered only once in 6 months. So it would be the preferred drug. Calcitonin is not very effective in osteoporosis, as we can see. And dihydrotachysterol is a vitamin D analog. So denosumab is better than both of these drugs. And infliximab is an anti-TNF antibody used for rheumatoid arthritis and inflammatory bowel syndrome. So our answer would be denosumab. Let's move on to the next question. What is the role of osteoprotegrin or OPG in the OPG rank L signaling system? The options are activation of rank R, secretion of rank L, it acts as a decoy receptor that binds rank L, or activation of osteoclasts. So first, let's learn a brief about the OPG rank L signaling system. So these are two images which are the same signaling system. So this is a stromal cell and osteoblasts are formed. Osteoblasts further release rank L and OPG. Rank L binds on rank R, which is present on the osteoclasts, and if it binds on rank R, it activates the osteoclasts, which results in bone resorption. But OPG acts as a decoy receptor, or rank L binds on OPG, which makes it less available to bind on rank R, thus reducing the osteoclast activity and reducing the bone resorption. So OPG is a decoy that binds rank L in the interstitial space and prevents its association with its receptor rank R. So The correct answer would be it acts as a decoy receptor that binds rank L. Hope all these questions are clear and it is helpful for competitive exams or any other purpose. And if you want to learn more in detail about bisphosphonates, there is another video which has a detailed explanation and it would be linked in the description box. Thanks for watching and please share this video. Thank you.